Acute aortic dissection may be present in only about 1 in 10,000 patients presenting to the emergency department. But missing an aortic dissection can be catastrophic. At the same time, submitting all patients with suspected dissection to imaging studies may not be feasible in view of the cost and potential risks. Hence, a good clinical bedside risk score may be useful in addition to diligent clinical evaluation. Aortic Dissection Detection Risk Score (ADD risk score) was formulated by IRAD investigators using the International Registry of Acute Aortic Dissection. 3 groups of high-risk features have been evaluated. High-risk conditions: Marfan syndrome, family history of aortic disease, known aortic wall disease, recent aortic manipulation, and known thoracic aortic aneurysm. High-risk pain features: chest, back, or abdominal pain described as abrupt in onset, severe in intensity, ripping or tearing. High-risk physical findings: evidence of perfusion defect in the form of pulse deficit, systolic blood pressure differential, or focal neurological deficit in conjunction with pain. Murmur of aortic regurgitation which is new or not known to be old, along with pain. Hypotension or shock. Risk is calculated by the number of categories in which any single risk factor is present. If no high-risk features are present, ADD risk score is 0. ADD risk score is taken as 1 if any single high-risk category is present. If 2 or more risk categories are present, ADD score becomes 2 or 3. In ADD score 2 and 3, immediate imaging and surgical consultation are needed. In ADD risk score 0, imaging is considered if there is unexplained hypotension or mediastinal widening on chest X-ray without any alternative diagnosis. ADD risk score 1 is the intermediate category in which imaging will be considered if ECG and X-ray chest, as well as history and physical signs, do not suggest an alternate diagnosis. Imaging modality chosen in an unstable patient would be transesophageal echocardiography, though imaging the entire aorta with computed tomography or magnetic resonance imaging would give better yield in stable patients.